Good morning to all of you, and thank you very much for being with us this morning. These are my disclosure. I think we all agree that acute promyelocytic leukemia is the perfect word for MRD assessment in acute myeloid leukemia field. In that, APL is a paradigmatic example of a very effective application of MRD assessment. MRD assessment in non-APL acute myeloid leukemia is at an earlier stage of development, still imperfect if you want, but to the detractors of minimal residual disease detection, I remind that the alternative is stepping back to the morphologic evaluation of complete remission of response. So in my presentation, I would like to touch on, to tell you something about retrospective, prospective studies, and of course, going to the core of my presentation, MRD and transplant. This experience is, let's say, a paradigmatic example demonstrating that there is nothing complete about complete remission. This is a series of pediatric patients that were followed at the St. Jude's Hospital in Memphis. The patients were, the investigators collected more than 1,000 bone marrow samples after induction 1 and induction 2. And these samples were evaluated morphologically and by flow for the persistence of measurable residual disease. Actually, from a morphological point of view, the samples were categorized in 3 groups: complete remission, less than 5%, those with 5 to 15% bone marrow blast, and those with more than 50% bone marrow blast. At the same time, flow was used to detect MRD, with 0.1% being set as the threshold discriminating MRD negative and MRD positive patients. And you can see that among patients declared in complete remission, less than 5% of bone marrow blast, 8% were MRD positive. At the same time, among those who were not considered in morphologic complete remission, 67% and 16% were MRD negative. This was not a mere investigational exercise, because these results translated into a prognosis. You can see that whatever the percentage of bone marrow blast, the duration of event-free survival was the same if MRD was negative. And when the authors focused on the 2 categories, less than 5% bone marrow blast and more than 5% bone marrow blast, you can see again that MRD was the driver, with patients who were MRD negative having the longer duration of event-free survival. In our experience, we analyzed for MRD persistence 142 adult patients with acute myeloid leukemia who were recruited to a sequential series of ERTC-GMEMA protocol. MRD was investigated by flow, and we selected the threshold of 0.035% as the threshold discriminating MRD negative and MRD positive patients. You can see that at both the time point considered, post-induction and post-consolidation, patients who were MRD negative on the blue line had a longer duration of relapse-free and overall survival. Important to note, in multivariate analysis, post-consolidation MRD status was an independent factor affecting duration of relapse-free survival and overall survival. Also, the colleagues from the Ovon SAC demonstrated and confirmed the importance of the prognostic role of MRD evaluation. At any time points that the authors considered, induction 1, induction 2, consolidation, patients who were MRD positive had higher rates of cumulative incidence of relapse on the yellow line, here, here, and here. And finally, we have the more recent, very the more recent and very robust data published by the colleagues from NCRI. The colleagues concentrated on patients with NPM1 mutated acute myeloid leukemia, and they evaluated the persistence of the NPM1 transcript in peripheral blood after the second cycle of chemotherapy. And again, patients who were MRD positive had a shorter duration of overall survival and a higher frequency of cumulative incidence of relapse. Based on this, several groups activated MRD-driven or MRD-stratified clinical trials, and I'll show you some examples of these ongoing prospective trials. This is the UK NCRI AML 19 trial, and you can appreciate that for both NPM1 mutated and unmutated leukemia, there is in the red text, there is a dedicated intensified program for MRD positive patients. MRD positive patients are randomized between an intensified approach consisting in CPX or FLAG-IDA, and then the patients are submitted to an allogenic stem cell transplant. This is of an MRD-driven or MRD-guided approach. This is the OVEN trials, and you see that for good and intermediate risk categories that are MRD positive, the program consists in delivery of an allogenic stem cell transplant. Also, the GMEMA group developed a program like this. This is the AML 1310 clinical trial. That was a risk-adapted MRD-driven clinical trial in which patients belonging to the intermediate risk category were to receive an autologous or an allogenic stem cell transplant based on the level of minimal residual disease as measured by flow after the first consolidation. Coming to the core of my presentation, I would like to show you the experience that was published by the colleagues from Fred Hutchinson Cancer Center in Seattle. They demonstrated that patients who were in a retrospective analysis, they demonstrated that patients who were pre-transplant MRD positive had a duration of overall survival and event-free survival that was equivalent to the one of patients with active disease. So you can see on the gray and yellow line patients who were MRD positive pre-transplant and who had an active disease. I'm afraid that many from the scientific community in a way misinterpreted these data as a sort of no-go signal for a transplant procedure to be delivered in situation of a pre-transplant MRD positivity. Even though the colleagues from Seattle made a very strong argument for caution in adopting a transplant procedure in these patients, I think that this data should be interpreted in the light of some considerations. First of all, the experience published by the colleagues was a retrospective one. They included a very heterogeneous population of patients, younger and older. They included a very heterogeneous spectrum of conditioning regimens. And finally, by chance, there was a high concentration of adverse karyotype and secondary acute myeloid leukemia in the group of MRD positive patients. Indeed, indeed, we have indication that MRD-positive patients can benefit from the application of an allo transplant procedure. The colleagues from NCRI focused on patients with NPM1 unmutated acute myeloid leukemia, demonstrated that those who were MRD positive benefited better from an allograft, whereas those who were MRD negative benefited from no allograft approach. In the French experience, the authors concentrated on the category of patients with NPM1 mutated FLT3 ITD positive patients. They categorized the patients in two groups: MRD negative, achieving at least 4 log reduction of the baseline transcript, and those considered MRD positive, achieving less than 4 log reduction. And you can see that if we focus on the we focus on this group of patients, those who were not transplanted on the gray line had the shortest duration of overall survival. Same experience published by the Dutch colleague, pointing to the role of GWL effect in patients who are MRD positive. Actually, they observed that MRD positive patients who were allotransplanted had a lower incidence of relapse and a longer duration of relapse-free survival. In the GMM experience, we demonstrated that patients belonging to the intermediate category who were MRD positive, if allotransplanted, had the same duration of overall survival and relapse-free survival as those who were MRD negative and who were auto-transplanted. Finally, just let me point out the experience published recently by Chris Oregan, pointing to the importance of the conditioning regimen in patients who are MRD positive, pre-transplant MRD positive. Actually, in patients who were NGS positive before the transplant, the patients who were NGS positive before the transplant and who received a myeloablative conditioning regimens had a lower incidence of relapse as compared to those who were NGS positive and received a reduced intensity conditioning regimen. Going to the conclusion, I think that being MRD positive before the transplant should not be a contraindication. Okay, being positive, MRD positive before allogenic stem cell transplant should not be a contraindication for the transplant to be delivered. Sorry, I don't know what is going on with the slides. I'm not moving. Okay. And I think that based on this, we have 3 different levels of intervention, a sort of prevention level, adding on top of chemotherapy new agents that we have available. This is, of course, in the attempt to reduce the number of patients who are MRD positive before the transplant. We have a second level of intervention, implementing allotransplant efficacy, managing appropriately the conditioning regimen based on the data published by Chris Oregan. And then a further level of intervention that is the post-allogenic stem cell transplant maintenance. We have paradigmatic example from the use of FLT3 inhibitors after the transplant in FLT3 mutated acute myeloid leukemia. What I would discourage, I mean, this is my opinion, is to attempt to revert the MRD positive status before the transplant, because in this situation, the patients can get a relapse. Thank you very much for your attention.